It's with great pleasure and a massive honour to have Paul Mitrofanoff here today and for him to be able to talk to us about the procedure to which he created.
Thank you, Kara. Some months ago, I was browsing on internet, and as everybody usually does, I entered my name into Google, and I had a big surprise to find the Mitrofanoff support site. It was a surprise for me. I didn't know that it existed. So I wrote to Kara, she answered, and she invited me, and so I'm here today, and I'm very pleased to be there today. My name is a Russian name. In Russian, we pronounce it Mitrofanoff. In French, we used to say Mitrofanoff. But I now resigned to accept the English version of Mitrofanoff. Even on the site, it's advised to pronounce Mitrofanoff. Okay, that's no problem. When I'm in France, I hesitate. Originally, I'm a pediatric surgeon. I was appointed in Rouen, which is a very nice city between Paris and the Channel, in 1968. I was appointed as a pediatric surgeon. When I arrived there, I had to deal with many cases of spina bifida and, of course, many cases of neurogenic bladder due to the spina bifida. At that time, in the 60s, the late 60s, there was any satisfactory solution to treat such neurogenic bladder. One of the solutions was for some boys to wear such kind of device, very uncomfortable, with a bag. And for many of the patients to have a free diversion through a piece of bowel, and to wear a bag which had a very bad reputation. Wearing such a bag has a very bad reputation because of the skin lesions, because of the leakage of urine. Nowadays, probably the devices are much better, but even the wearing of a bag, permanent wearing of a bag, is not well supported by the patients. The first most important revolution came from Lapides, who introduced the principle of clean intermittent catheterization. Intermittent catheterization was used before him, before 72, in late 60s. It was used in institution, in hospital, treating patients with spinal cord injury. And in such conditions, the catheterization was done by a team of nurses, devoted team of nurses, specialized for the catheterization, and doing this catheterization in a very drastic, sterile manner. They had to wear gloves, to make a washing. It was very drastic. And then Lapides taught some of his patients to do the catheterization, and even to do self-catheterization, but always with such drastic sterile conditions. And well, maybe you know this, the story tells that one of his first patients, while traveling in Europe, as she was prepared to do the catheterization in public restroom, maybe in France, she dropped the catheter, sterile catheter. She was unable to re-sterilize it, and she did the catheterization without developing any infection, any illness. She told that to Lapides, And after that, Lapides realized that it's really important to have a very sterile catheter to do the catheterization. It's not so important to introduce with the catheter some bacteria, provided the bacteria are carried away immediately by the emptying of the bladder. And if the emptying of the bladder is repeated several times a day, it's a good way to prevent the infection, which was the supposed risk before that. And he published that in 1972, his first series of self-catheterization in patients with neurogenic bladder. After that publication, many hospitals, many centers started to use intermittent catheterization and self-catheterization. It worked in some patients, but very often it didn't work. Why it didn't work? For two main reasons. The first is that between the catheterization, very often there was a persistent and variable leakage of urine. And the second reason was that for some patients, the self-catheterization was very difficult to achieve because of orthopedic or anatomic or psychological reason. They couldn't do the catheterization. So we had to find a way to avoid these two problems, the leakage and the difficulty for catheterization. For the leakage, I had the idea to close the bladder neck definitively. It could be a good way to prevent leakage by the urethra. And of course, doing in the same time another channel to catheterize the bladder. Fortunately, nature has placed by the bladder an organ quite useless, which is the appendix. Useless except for creating an appendico-vesical stomach. So the idea came, you are asking how came the idea? The idea came that the bladder there, the appendix there, and to use both of them and to place the appendix to the bladder to create the new channel. We knew at that time how to realize an anti-refluxing mechanism at the tip of the appendix, so to realize channel easy to catheterize by anybody and to have a non-refluxing channel in the bladder. That was the ideal. To be totally honest, I must say that I was not the first one to have the idea to use the appendix in a urologic situation. In 1910, a neurologist, I don't know, I think maybe it could be German, I think, used this kind of procedure to replace a bladder and to fix the appendix to the skin. But I don't know if it was continent, probably not continent, and probably not to be catheterized, just to drain the urine. That was the first use of appendix. Here is my first patient with an appendico-vesical stomach. It was in 1976. This boy was 16. He had spina bifida with a severe neurogenic bladder, but not too severe orthopedic problems. He tried to do the self-catheterization via the urethra, but he kept some sensitive urethra and he totally refused to do the self-catheterization by the urethra. And of course, he heard about the diversion, the free diversion, and the wearing of the bag, and he totally refused a solution where he had to wear a bag. So I discussed with him and I proposed this solution, telling him that if it doesn't work, we return to the free diversion. the bag. He accepted. I did that in 1976. 2 weeks later, he started the catheterization. Then he became a doctor. He's now a GP in the Paris suburb. I spoke with him a few weeks ago. His Mitrofanoff works very well. He is very happy at that. He catheterized about 5 times a day and has done probably more than about 500,000 times. I published my first series in 1980 in French. It was in French because it had been refused by the British Association of Pediatric Surgeons. They refused it. So I published it in French. But I met 2 surgeon pediatric urologists of Philadelphia, which are John Duckett and Howard Snyder. I discussed with them, and they started to use this kind of direction. And they published their series in 1986. And from that publication, the procedure was known around the world and spread very largely, widely around the world. And it was applied not only for neurogenic bladder, but only for different other pathology, as Dan said today, and also in adults in case of new reservoir replacing bladder after cystectomy. In the first cases, I had the idea that if the bladder is not too large, it's normal since it was leaking all day long. But if we close the bladder neck, this bladder could develop and acquire a good capacity, a good volume. Unfortunately, that was totally wrong, and in some of the first cases appeared some complication of dilation of the upper urinary tract. At that time, in the 80s, the concept of low pressure reservoir was not very much clear, not very much known. And only after such complication, it appeared necessary to deal with the pressure, not only with the capacity of the bladder, but with the pressure in the bladder, and to have a reservoir with a low pressure. For that, as Dan said, the best way, one of the most used way, is to enlarge the bladder with a piece of bone, and which is done in many patients, or in the same time at the diversion, or later on if necessary. In some cases, the appendix is not available. You know the technique of Monty, which creates with a little piece of bowel a tube, a thin tube, which looks very much like an appendix. It can replace the appendix when it's not available. In this patient with a neurogenic bladder, spina bifida especially, there is a very frequent problem, which is the anal incontinence due to severe constipation. And the progress was achieved by Pat Malone, who described the antegrade continence enema using the appendix or another tube to create a continent cecostomy, which permits the enema from the cecum to the anus, and to wash completely once or twice a week the colon, and to obtain good continence, anal continence. That was also a great progress for many patients. One persisting problem, you heard about it this morning, is the problem of stenosis, of stomal stenosis. Different procedures have been described to prevent and to treat that, but there is not yet a universal solution. This is to be found. Then it's up to you to find the solution for the next 3 years. But in most of cases, we can hope that patients with such continent diversion, even associated with cystostomy for enema, can have a very good quality of life, like this boy who had this procedure 20 years ago and who lives still a very normal life. The aim of your Mitrofanoff support is also to give a good quality of life to the patient with such a diversion. And thank you for that, Kyla, and thank you for your job. It's a very good job. Thank you for it.